Hi, welcome to this episode of Conceptual Anesthesia, in which we'll be talking about toxidromes. When patients present to you unknowingly, sometimes when you don't realize what toxins they have ingested or there is some unknown poisoning, so that is when you have to think about what can be a kind of toxidrome. So, we'll be seeing what is a toxidrome, what is a patient who can present with a toxidrome, what are the various toxidromes, how to diagnose one toxidrome, and how do you treat and manage these toxidromes. It will be a very interesting class, believe me. So what happens? Sometimes there's a patient who's dropped off at the emergency door. He is minimally responsive. His friends say that he took something and they drive off. Or some young woman or some patient is brought to your casualty or emergency, and there is a alleged history of find her unconscious in a room with an empty bottle next to her. And we all encounter these kind of cases during our clinical practice. So what do we do? How do we diagnose? How do we think? What is the patient suffering from? Is it easy to diagnose? Is it difficult? So how do we think that ways? So these are the various poisons that or toxins that can be ingested. There's a long list. If you see, the list is growing every day with newer agents for recreational drugs being added to this, newer medications being added. So they can all be ingested in a higher dose and act as a toxin. So what is a toxidrome exactly? A toxidrome is a group of signs and symptoms constituting the basis for a diagnosis of poisoning. So we have a syndrome, and similar to syndrome, there is a word called toxidrome, which is related to toxicology or toxin ingestion. Remember, this may be the only clue. So this toxidrome or the suspicion of a ingestion of a toxin with the various signs and symptoms is maybe the only clue for diagnosis. Diagnosis can be complicated by possibility of multiple drug injections. So there are many patients who come to us with multiple drug injections, and we have to. This is a diagnosis of exclusion sometimes. So we have to think what the patient could have taken. We should suspect certain things. We should see the signs and symptoms. Try to diagnose them. So a toxidrome, in other words, is a syndrome that specifically relates to a specific toxin. And many toxidrome symptoms are subtle and overlap. So as you will be telling you the signs and symptoms, you will be seeing they'll be not easy to differentiate always. So thorough assessment of a patient who has ingested a toxin is essential. So the approach to this patient usually is two-pronged. Firstly, we want to diagnose what is the toxin that this patient has taken. And second is that we want to treat the patient simultaneously because this is a medical emergency that has come up to us. So we'll be talking about all of this in bit of detail. So we have to have a complete history, but history is not available at these times. These are the patients who are mostly unconscious or unresponsive or mildly responsive and under the effect of the toxin. So the history is often incomplete, unreliable, and in some cases unobtainable. Usually the sources are patient, friends, or there is suspicion looking at empty containers and the location of ingestion of toxin. Always try to find out the history of previous medications. So whatever the patient is taking as a medicine, that is ingested in a larger amount, can amount to a toxidrome or a toxin ingestion. Look at the history of previous overdoses, substance abuse, and medical legal reporting. Always examine the patient for his vital signs first. Look at the pupillary size, the neurological response, the skin, the odors, and I'll be telling you what are the signs and symptoms that have form a toxidrome. So basically, it's the autonomic effects of the toxin that is in question that can form as a toxidrome. So effects that are caused by the ingestion of a certain alleged toxin on the eyes, skin, secretions, and other vital signs. And this all signs and symptoms forms the toxidrome, and this helps in rapidly narrowing of a diagnosis in a differential of a patient of toxidrome. So when you examine the patient, look at these. These are the certain toxins that could have caused bradycardia. So propranolol, anticholinesterase drugs, calcium channel blockers, digoxin, antiarrhythmics, they can all cause bradycardia. So try to remember this. They have a mnemonic called PASTE for this. Then there are certain drugs which could have called tachycardia. So all sympathomimetic drugs like cocaine, caffeine, amphetamine, tricyclic antidepressants, higher dose of injection of thyroid hormones, anticholinergic drugs, amphetamines, antihistamines. This is by the mnemonic of fast. These are the toxins which may cause tachycardia. Then there are toxins which are called hypothermia. So majorly carbon monoxide, opioids, oral hypoglycemics, alcohols and sedative hypnotics, including opioids may cause hypothermia. Then there is something which called hyperthermia. So nowadays, neuroleptic syndrome, serotonin syndrome, they are all a part of toxidrome. So these some may call hyperthermia. So the mnemonic is NASA, and they may include salicylate, sympathomimetics, serotonin syndrome, neuroleptic syndrome, antihistaminics, anticholinergics, antipsychotics. They all may cause hyperthermia. So we should have a list of them ready with us, and we should suspect that these are the drugs that are causing this. So we have to be very careful when we diagnose these patients. Then miosis. So these are the drugs that can cause miosis. Miosis means when you do a pupil examination, pupillometry, small constricted pupils. So drugs that can cause are cholinergics, clonidine, carbamates. Another drugs that can cause opioids and organophosphates. Remember a differential diagnosis of pontine hemorrhage whenever you have small pupils, and sedative hypnotics. Then the toxins that can cause mydriasis. So large wide pupils when you do a pupillary examination. So sympathomimetics, anticholinergics and withdrawal of any drug may cause mydriasis. So when you look at the heart rate, the temperature, the skin and the pupils, so you can form a differential diagnosis. So then after doing examination, you suspect something, you send investigations. You do a chest X-ray. Always we check blood glucose because this is a mimic for any toxin ingestion. Hypoglycemia should definitely be ruled out. Then ABG must be done. We should always calculate a serial osmolar gap. Toxicology screen of various body secretions can be sent at different laboratory. Then abdominal X-ray is sometimes required for drug trafficking rule out. And when you do a blood gas analysis, we have to look at high anion gap metabolic acidosis. So all of these, what I'm talking about, can give you different small clues. No one thing is certain, but they are all giving you clues to certain diagnosis. So things which can cause a high anion gap metabolic acidosis are methanol ingestion, ethylene glycol ingestion, toluene, alcoholic ketoacidosis, lactic ketoacidosis, histamine fen overdose, cyanide, isoniazid, diabetic ketoacidosis, paraldehyde, salicylates, some seizure producing toxins. So they can all cause high anion gap metabolic acidosis. Then we should know the osmolar gap. Osmolar gap is measured serum osmolality minus the calculated serum osmolality. So normal osmolar gap is -9 to around -9 or -10. So drugs that cause elevated osmolar gap we should know, like ethanol, ethylene glycol, glycerol, glycine, methanol, and even things like high radio contrast media and mannitol can also lead to a elevated osmolar gap. So when you find something, you should have a checklist to rule out certain common things. Then oxygen saturation. So we also should have a co-oximetry. So co-oximetry, instead of two wavelengths, we have four different wavelengths, and we can directly measure the values of certain kind of different hemoglobin binding oxygen, like methemoglobinemia, carboxyhemoglobinemia, cyanide, and sulfhemoglobinemia. So these can all be found out if we have a co-oximetry. Usually, certain larger centers have a co-oximetry machine, and it is just like a normal blood gas analysis, and you have these values. If they are normal or less, it will come as less than some percentage. But if in very rare cases it increased, you have a suspicion of a certain toxin or exposure to a certain thing.